Chairman, to have finished the session on time. So thank you very much, sir. So without wasting any time, let's start our session. Our judges are Dr. Krishna Prasad, myself, Dr. Kashyap, Professor and Brigadier Gaurav Kapoor, and Dr. Viral Shah, and Dr. Chandana Kakati. So we start with the first speaker. He is Dr. Ashish Markan.
Yeah, okay.
He'll be talking on predictive factors for structural and functional outcomes of 25 gauge PPP and removal of posterior intraocular foreign body.
Okay, good morning to all. So I'll be talking about the predictive factors for structural and functional outcomes in cases of 25G partial vitrectomy surgery for removal of posterior intraocular foreign bodies. So there have been a number of studies which have actually looked at these predictive factors. But if you go and study these papers, the results are quite variable. Also, there are many factors such as the size of the intraocular foreign body, the removal of the route of extraction of these foreign bodies, and whether putting an encircling element actually helps or not. And there are many other factors which haven't been studied that extensively. So the whole idea was to actually conduct a retrospective study and to look at the predictive factors which could actually guide us to the structural as well as the functional outcomes. So it was a retrospective data analysis. All the necessary demographic details, the preoperative data and the intraoperative surgical details were noted. Also, we devised this classification and we divided the zone of impaction into zone 1, 2 and 3. Zone 1 was defined as where the intraocular foreign bodies were impacted within the macula. Zone 2 was whether the impaction was present outside the macula but posterior to the equator. And zone 3 was where the impaction was present anterior to the equator. All the surgeries were performed on constellation vitrectomy system, and lensectomy was performed in all the cases of traumatic cataract and in cases where intraocular foreign body size was more than 5 millimeters. Also, the primary intraocular lens implantation was not performed in any of the cases requiring lensectomy. And decision to put an encircling element, the route of intraocular foreign body removal, and the choice of intraocular tamponade was decided by the operating surgeon. The structural and the functional outcomes were studied at 1 year of follow-up, which included the best corrected visual acuity, the retina status, and the presence or absence of epiretinal membranes. The functional success was defined as BCVA better than 6/60 at 1 year of follow-up, and the anatomical success was defined as no retinal detachment involving the macular area at the time of last follow-up. Univariate analysis was applied to study the associations. Coming on to the results, so 39 patients were included with 37 males and 2 females, and the mean age of the study population was 30.5 years. Majority of the injuries were workplace related, followed by home and domestic accidents. So if we see, majority of the patients had a zone 1 injury, and we had about 66% of the foreign bodies which were impacted, and majority of them were impacted in zone 2 and zone 3. Most of them were metallic foreign body, and we performed most of the surgeries within 2 weeks. Also, about 59% patients had an encircling element being put. The associated retinal detachment and end-off was seen in 20 and 30% patients respectively. Lensectomy was performed in majority of the patients, and the foreign body was removed through limbal route. So we also divided the size of the foreign body as small or large, depending on less than 4 millimeters or more than 4 millimeters. So at end of 1 year, the mean BCVA improved significantly. The retina was attached in 82% of the patients, and epiretinal membrane formation happened in 23% of the patients. So now coming on to the most significant part, the association between the retinal attachment or detachment and these independent variables. So when we applied the univariate analysis, we found that none of these factors, that is the zone of the injury, zone of impaction, whether the foreign body was impacted or not, timing of the surgery, if there was an associated retinal detachment or end-off, if we performed lensectomy and removed the foreign body to the anterior route, or the size of the foreign body, did not have any impact on the structural outcomes, whether it was retinal attachment or detachment, or whether it was the formation of postoperative epiretinal membrane. But when we studied the association between the functional outcomes and these independent variables, what we found was that 3 factors, they were important. First was the impacted foreign body, second was the associated end-off, and third was the size of the foreign body. So if the foreign body was impacted, there was presence of a preoperative endophthalmitis, and the size of the foreign body was more than 4 millimeters. These 3 factors were associated with a poor visual outcome, that is less than 6/60. So just to conclude that the presence of intraocular foreign body, which is impacted, an associated endophthalmitis, and a large intraocular foreign body are associated with poor visual outcomes. And none of these independent variables had an association with the postoperative structural outcomes. Thank you.
What was the new data that you have got out of the study? If you do the ocular trauma scoring, these factors are already known.
So the whole, like at our center, it is always said that you have to put an encircling element, because there was this study by Dr. Azad, which came up in 2004 or 2005, where they said that you put an encircling element and the structural outcome is much better. But that study was done during the age of 20 gauge vitrectomies. So what we found that putting an encircling element actually does not help. Second, apart from that, when we were looking for other factors also, we decided to look at the structural and functional outcomes for other variables, where we found that the size actually matters and the endophthalmitis, it matters. So it was just our own experience of our cases which we have done, and that is it.
You said about the impacted foreign body.
Yeah.
How does that actually independently influence the outcome? Can you give some reasons?
So, sir, basically, most of these impacted foreign bodies were in zone 2 or zone 3. Majority of them were in zone 2. So we had to perform a large chorioretinectomy in some of these cases. And that could have actually led to maybe a formation of an epiretinal membrane or something which could have affected the visual outcomes.
Normally we are retinected with good barrage, and normally that since it is away from the central fundus, it normally does not really influence the visual outcome, right? So, I mean, in that case, do you have any kind of cases in which the impacted foreign body has resulted in ARM?
Ye-
Foreign body which was free and easily picked up. There was
We didn't actually look at separately at the effect of impacted foreign body with an epiretinal membrane, but when we looked at it, though epiretinal membrane was not coming significant, the formation, but it had an impact on the, maybe because the size of the foreign body was very large, or maybe it affected the zone 1, that could have led to a poor visual outcome. We are not clear about that.
Regarding your lancectomy, how many cases you have done in the first sitting, or how many cases you have done
So
in the
about
second sitting?
80% of the patients, they underwent lancectomy in the primary sitting only.
Why? Because sometimes cataract develops a very long time to
No,
develop.
but 70% of them initially had a cataract. So
In your study, right?
in our study,
But
yeah.
that's not that common, because most of the cases, sometimes they develop cataract very later.
because about 60% of them had a zone 1 injury, and if it is a zone 1 injury, we expect that cataract would be present because it is passing through the cornea and going behind in the posterior segment. And
Okay, fine. Did you do any clear lens extraction as well?
no, clear lens extraction was not done. I think in 1 or 2 cases where the size of the foreign body was roughly 15 or 16 millimeters. There were 1 or 2 cases. In those cases, we had to do because we planned to remove it from the anterior root, the limbus.
Okay.
Did you do a pre-operative trauma scoring?
No,
See, that is where if you have a pre-operative trauma score which predicts a poor outcome, and then you can predict which of your factors were in contraindication or different from what the trauma score predicted.
This has almost same features. Or presence of foreign body, presence of endophthalmitis, they're all already there in the
Trauma scoring.
okay. Thank you.
Thank you.
Our next speaker is Dr. Vaishya Vagat. She will be telling on clinical analysis of ocular injuries in school-going children. Vaishya, please.
Good morning, everyone. Good morning, everyone. My topic is clinical analysis of the ocular injuries in the school-going children. Ocular trauma is a major cause of the preventable monocular blindness in the world. It accounts for 8 to 14% of the total injuries in the children. And ocular trauma leads to the visual impairment, cosmetic problem, and is associated with the psychosocial problem. Most of the ocular trauma is preventable by simple measures, literacy, and awareness. Visual loss due to the trauma is irreversible, and hence prevention of trauma is of paramount importance. Aim of the study was to identify the cause, demographic, and the clinical profile of ocular injuries in school-going children, to evaluate the final visual outcome, to explore the possibilities of the prevention of the visual loss. It is a prospective analytical study. Sample size was 60, was done from December 2022 to May 2023, was conducted in school-going children of the age group of 5 to 18 years. Inclusion criteria were 5 to 18 years of age. Boys and girls were included in the study. Unilateral and bilateral involvement on all modes of injury was included. Exclusion criteria was less than 5 years old, more than 18 years, pre-existing ocular morbidity, congenital anomalies. Detailed workup was done of the patient with ocular trauma, which included a detailed trauma history, pre-existing ocular and the medical disease, visual acuity, complete ophthalmological examination, and radiological investigations. Result was seen that most of the age group involved was 11 to 15 years, which were 13 number. Boys were mostly involved, almost 47, And the mode of injury, out of 60 cases, accidental fall was the most common cause of the injury. 20 cases were recorded, almost 33.3%. Eyes involved were almost equally involved. Ocular involvement, out of the 60 patients, most ocular manifestation was lid involvement. Almost 53 patients were seen. In the study of the 60 cases, 24 has periorbital edema, 27 has periorbital ecchymosis. The most common ocular manifestation is periorbital ecchymosis followed by periorbital edema. Out of 60 patients, subconjunctival hemorrhage was mostly seen in 40 patients. Cornea involvement epithelial defect was seen in 6 patients. Scleral tear was seen in 2 patients, and anterior chamber reaction was seen in 5 patients. Pupillary RAPD was seen in 4 patients. Traumatic cataract in 1, posterior segment involved in 3 patients. Cranial lumps, 4 optic nerve involvement was seen in the orbital. Lateral wall fracture was seen in the 4 patients. Type of injury, mostly closed crop injury was seen. Vision at the presentation, out of the 60 cases, 18 presented with visual acuity of 6/6, 21 between 6/9 to 6/12, and 8 in 6/18 to 6/36, and 6 were 6/60 to 1/6, and 1 is close to phase, 5 had a PL, and the 1 has a no PL. Visual outcome was seen that out of 60 patients, 39 had visual acuity of 6/6, 9 has 6/9 to 6/12, 2 had between 6/18 to 6/36, and 4 had between 6/60 to 1/60, and 1 had finger counting close to phase, 3 had PL present, and 3 no perception of light was seen. Discussion was seen that 11 to 15 years were the most commonly age group involved. Boys were mostly involved. Accidental fall injury was the most common cause of the injury. Unilateral involvement was more common than the bilateral involvement. The most common ocular manifestation was lid involvement, followed by conjunctival injuries. Closed globe injury was mostly seen. The final visual outcome of no perception of light of more common seen in the road traffic accidents. Coming to the conclusion, ocular trauma is a leading cause of the ocular blindness in the world today. It is causes a lifetime disability in the children. Education to the parents and students about watchful inactivity, importance of supervised play, and the road safety measures is very critical. Appropriate ocular protection and the adult supervision for children must be stressed, especially when using the sharp object. Prevention of accident and the early detection and management can prevent visual disability.
Please conclude. Yeah.
Dr. Varsha,
Yes.
It's working, sir.
what is your research
feedback,
question?
Uh,
I'm
sir,
really
in my
curious
study-
about your study, because I really didn't get any what exactly you are trying to study. You are taken as you are saying as school going children.
Yes, sir.
Nothing in the school going aspect to the study, number 1. It's just the age group between 5 to 18.
Yes, sir.
Okay. So basically, and you have included starting from subconjunctival hemorrhage to traumatic optic neuropathy. Such a wide, almost everything in the ocular trauma book you have included.
Yes.
So how can you actually stratify the data and give a conclusion? And you have never introduced the element of at least the terminologies like the most common Birmingham's terminology that vets we have. So like, for example, if you are studying closed globe injuries, you are studying, IOFBs, if you are studying, ruptures, then there is an element of analysis and interpretation. But this is a very diverse, absolutely unrelated, group. And how can you come to what exactly what you are trying? What is your research question in this study?
So in my study, I have seen that mostly 11 to 14 years were involved, in which
What do you want to study?
the most common cause, what was the cause of, yes, sir.
Question. What is your research question?
So clinical analysis, that is to see the demographic profile and what were the causes. And I have seen that mostly it was the sports activity or the physical activity in the schools that led to the trauma mostly seen in that age group.
I mean, your physical education period was the cause of trauma.
So physical activity
Then
like
you should take it out
sports.
from the school.
Yeah,
sports
one more
activity
thing
or
is
the-
that you said that the age from 5 to 18, 18 do they stay in the school? And number 2, probably she means that, so because there are a lot of lead injury cases, so an ocular plastic surgeon should be posted in the school. Is that right? Because they are most common one. So if any eye specialist of any subspecialty, and it should be oculoplastic rather than the vitreoretinal surgeon. Anyway, any more question? Yeah.
It's a prospective study. How did you make the prospective study? You have followed up the cases or like that?
Of almost 3 months I have followed just.
Or you did it better, it was a retrospective study maybe?
Uh,
What do you think?
no ma'am, it's just a perspective because
Okay.
yes ma'am. So I have done the follow-up up to 3 weeks in a 1 week, and according to the severity it was followed by 1 week and followed by 1 week and then after 1 month.
You said the second most common cause of injury was injury with sticks. What does that mean? Matlab, stick related injury in the school
So children are playing with the sticks and
with the stick, and the school should be penalized, not the students. If they have access to that. What we are saying is commonest in the younger age group is actually pencil related sharp object. That is the commonest cause of trauma. I don't know, your data is going in a totally different direction. Commonest in the school is the pencils injury, lead pencil.
I mean, do you mean that the injuries happen during the school hours?
Or
What you are trying to say, or it is
even outside the school.
so
the injuries happen during the school hours?
Or outside the school also. That's what sir is asking.
so outside the school hours were also included.
Road
in this
traffic
study.
accidents tha na.
Sure, thank you, Varsha.
So next is Dr. Joyita Das. Dr. Joyita, yeah.
Good morning, everybody, respected judges. Slides, please. It's not coming. Yes. Today I'll be discussing on delayed diagnosis of intra-orbital foreign bodies, 6 years retrospective study on 18 cases. We all know that intra-orbital foreign body is an important cause of ocular morbidity, and intra-orbital foreign body is notorious for delayed presentation, and it is diagnosed after few days to weeks after initial injury. It occurs after a high velocity injury such as gunshot and workplace related injury. The management of intra-orbital foreign body depends on the composition of the foreign body, location, visual potential of the eye, and presenting sign and symptoms. The diagnosis treatment of this poses a challenge for majority of the ophthalmologists. So, to analyze the clinical presentation, diagnosis, management strategies, and prognosis of delayed diagnosed cases of intra-orbital foreign bodies treated over 6 years of period from 2016 April to March 2022, a better understanding and avoid delayed diagnosis of intra-orbital foreign body, this study has been done. This is a retrospective interventional case series of 18 intra-orbital foreign body cases treated by surgical exploration. The place of study is Disha Eye Hospital, tertiary care eye hospital in Kolkata over 6 years of period. Now come to the result. The mean average age was 33.55 years. Gender here male outnumbers female, most are male. The median presentation time after injury was 6.5 weeks. Minimum was 3 weeks and maximum was 54 weeks. The mean time lapsed to diagnose the organic foreign body was 11.28 and the metallic foreign body was less, that is 6 weeks. The nature of foreign body are most common in my series was foreign, that is wood, metal followed by wood. And the mode of injury, the commonest mode of injury was workplace related injury followed by road traffic accident. Now come to the location of the foreign body. It is most common in superonasal location followed by inferomedial and superotemporal, next inferotemporal. The 55% of the mass of the foreign body was extraconal and 44% was intraconal. And among the presenting symptoms, dimness of vision was the most common, followed by pain, diplopia and swelling. This is the summary of the clinical profile and management outcome of the cases of my series. You can see the earliest case detected in 3 weeks period, and the most delayed was 54 weeks. And there is one interesting case was is a child of 12 years has an injury by mobile blast while playing with a mobile phone. And in imaging pattern, the CT scan was the most commonly done image, and outcome was it was most common, the better were out by 20 by 20 to more than 20 by 60 in most of the cases. Only 2 cases has no PL after management. So this is the first case I'm showing. This is a 30-year-old gentleman presented with left eye injury 3 weeks ago while working in a factory. Chief complaint was persistent redness. His best corrected vision on 6/9. There was a fleshy mass with congestion. In the ocular movement, there is left eye has a limited adduction, and in the opto scan you can see there is some streak of the traces of vitreous hemorrhage, localized retinal elevation, suspected perforation. And this is the CT scan. You can see there is a metal foreign body which is present near medial rectus muscle insertion. The management was orbital exploration followed by intraoperative barrage laser under general anesthesia, and this 17mm iron nail was retrieved. Patient went back to 6/6 vision after 6 months. This is another case of a fisherman who was attacked by a armed pirates while fishing 3 weeks ago. He presented with vision 6/12, and he has proptosis. Just finishing. Proptosis and some limitation of movement in abduction and superior temporal gauges. This is the foreign body we found, and after surgical exploration by transconjunctival orbitotomy, a 4mm pellet was recovered from the intraconal orbit abutting the lateral rectus. This is the case 3. This is a RTA.
Time is over.
patient. Yes,
Your
sir.
time is over. Please.
Yes, sir. This I'm just concluding.
Go to the conclusion.
Yes, sir. In this study, the organic foreign body are most often presented in the late cases. CT scan is the imaging of choice, and in my series, workplace-related injury as the leading cause of intraorbital foreign body. So, use of protective device in the industrial workplace is highly recommended. Even if presented after a long period, it can be managed by appropriate surgical and medical intervention. Thank you.
See, it's called a delayed presentation of foreign body, but your presentation cannot be delayed so much. You're only given 4 minutes. And first 50 seconds, I was just counting, you were on a slide which had no relevance to the topic. You are studying, it's a wonderful study, excellent study. You are supposed to present in 4 minutes. You should have come to the brass tack right from the word go. 50 seconds you spoke on general aspects of trauma, or orbital trauma, which had no relevance to the actual study. You could have shown us all the cases, very well documented. So basically we still understand exactly what is important. See, there has to be some takeaway from your study. You have to enrich the existing literature. These are the things which went into the orbit, some people even did not know. And you have done MRI for many cases. How do you actually know that the foreign body is not?
In all cases, first we have done CT scan,
Okay.
and in those cases where it is excluded that there is no metallic component, or where there is confusion
scan
that
was
there is no
That's
foreign
fine.
body,
That's
in those
okay.
cases I have done MRI.
Then okay. Then now can you tell us, like, was it the history taking that was important in suspecting the retained intraorbital foreign
This is
body,
very
or
important.
was it the clinical findings?
So both are important in
No.
our.
I don't want a theoretical answer. I want in your study what you extrapolate. See, every study has to give us some information. Okay. So in my experience, I would many a times retained intraorbital foreign bodies are silent outside. We
Yes.
may not have any telltale sign. It is not like you have a corneal entry point or a
Exactly,
iris
sir.
hole. Orbit, it can just go through the conjunctiva and it can get in the coats or get lost in the orbit.
Yes, sir.
So what was there? But the history sometimes, so in your case, what was the basically methodology? What are you trying to tell us from your study?
No. The delayed presentation sometimes you're absolutely right. They are missed by the previous ophthalmology. They have already consulted. They have missed the thing, but then they presented with some symptoms like diplopia, or in many cases discharge and dimness of vision. In those cases, again we have taken. In dimness of vision, the causes are in 2-3 cases. There was some lamellar the placement of one of the cases. Second cases I have shown the foreign body was in a lamellar fashion. So there is some localized corneal edema and effusion also there. Some vitreous hemorrhage also stresses of there. So this could be another cause. And in the no PL cases, the foreign body was placed exactly right in the apex, towards the apex, and that traumatic optic neuropathy already had happened in 2 cases in my series.
And I saw that there was no B scan done in any case. In case of hazy median, you said there is some amount of suspected
So
detachment of vitreous hemorrhage.
No,
You
I have
should
not
have done.
presented the data here because I want to.
If you, since you are
yes,
talking about the investigation, you have to
Yes,
mention
yes.
about the B scan as well.
yes, that's mistake from my side.
What Dr. Krishna Prasad has said is absolutely right. Most of the times it is a detailed history that gives you an index of suspicion. If your history is not detailed, that is the reason they are delayed. not because of the symptoms coming late, it's because somebody has missed it and not asked the mechanism of injury, and the index of suspicion is not there where you don't suspect a foreign body. So that is what you should have been highlighting.
Yes, sir.
The
Especially the children, they don't tell.
even in
such a
adults,
thing. Adult also in our scenario, they don't tell the history properly. They sometimes miss a trivial trauma, but actually
it can come in the most unexpected of cases. I have had, apart from this, I have had a case, a 55-year-old serving JCO in the army. He has never had a history of trauma. When I did his cataract surgery, there was a foreign body embedded inside the lens. And he never reported it with any trauma. Suppose you saw this on table and there was a foreign body inside. So it can be as minuscule foreign body can enter, and it might not present for years altogether. So similar is in the orbit.
Is there any situation where you would like to keep the foreign body without removing it? Have you gotten through that kind of situation?
there are some situations that is very small inert foreign body, like glass foreign body. We can also keep if it is in a position like in an extracorneal position, not damaging to the optic nerve or any retina structure.
Metal?
Metal usually aluminium. This inert metal you can take, but usually we remove that iron foreign body. We should not keep. Some inert metal. There are some like.
Have you treated
aluminum.
gunshot injuries?
Pardon, ma'am?
Gunshot injuries with
yes,
pellets?
one case I have gunshot injury. Is pellet I have that is pirate injury in the Sundarbans area. Fishing.
All cases need removal or not?
Pardon?
All these cases to be removed or not to be left behind? What is your take?
Ideally, it should be taken because that pellet has some lead component and it may have toxicity later on.
So, Dr. Krishna, what do you say? Because if there is a patient is asymptomatic, there is no problem whatsoever, and it is asymptomatic, probably we can leave it alone if it is behind the eyeball in the cone. So, what is your take, Dr. Krishna?
After thorough investigation, the patient absolutely asymptomatic. No evidence of inflammation or infection or any motility problem or a vision threatening problems. It can be left because orbit is a Pandora's box. If you then try to take it out, you can cause more damage.
More damage, yeah.
So primum non nocere. Firstly, do no harm. Just watch.
So
Okay, sir.
we
Thank you.
deal with gunshot and blast injuries a lot more as compared to the civil. What generally the prime thing that we follow is what the books teach us. If it is a blast injury and if it is a gunshot injury, because of the high temperatures, generally these are sterile. So you will not have an infective component ever. So then it's based on the tissue reaction. If you have no tissue reaction, we have patients with 20, 30 embedded foreign bodies in the cornea, which we don't remove for years altogether. Nothing happens. Nothing happens. So
Thanks.
you have to be judicious in the removal also.
Okay, sir. Thank you.
So, can we move to the next speaker? Dr. Raj. Dr. Raj, are you around?
Dr. Raj Vadar? No, absent.
Next is Dr. Shivangi.
Dr. Shivangi Singh? Thumati Shivapriya? Yeah, she is here.
Okay.
Good morning, everyone. My topic is on Turston syndrome, comprehensive review and clinical analysis. Turston syndrome refers to oculocerebral syndrome with hemorrhage in vitreous subhyaloid subretinal space, even beneath ILM, associated with intracerebral bleeding. It is reported in 17 to 28 cases of SAH and 9.1% cases of intracerebral hemorrhage. It is a prospective study of 5 cases present to our tertiary center. We have diagnosis is primarily clinical with fundus imaging, OCT and CT. Pathogenesis, Turston syndrome is described most commonly in subarachnoid hemorrhages due to ruptured cerebral aneurysms. Other causes are strangulation, trauma, hypertension, tumor, etc. Main possible pathophysiology was transmission of intracerebral blood through optic nerve sheath and then thereby increasing the intracranial pressure and rapid effusion of CSF through this optic nerve sheath and then compressing the central retinal vein and then rupture of thin vessels from inertial injury and thereby hemorrhage. In case 1, 21-year-old male patient presented after RTA. He was admitted in hospital. After regaining consciousness, he complained of diminution of vision. Fundus imaging and B-scan revealed vitreous hemorrhage in both eyes. Patient was observed for 6 months. right eye vitrectomy was done, and left eye, after 6 months, spontaneous resolution was seen. Whereas in case 2, 45-year-old presented with RTA, he had brief loss of consciousness, and he had SAH and SDH, where he was admitted in NIMHANS, and he was treated for right frontotemporal parietal decompressive craniectomy with evacuation of acute SDH, and he was put on supportive care. After extubating, patient had diminution of vision. On fundus examination and B scan, there was vitreous hemorrhage in both eyes. Patient had to be treated in a center. Both eyes vitrectomy was done. Whereas in case 3, 24-year-old patient with history of RTA with CT brain suggestive of EDH. On examination, right eye showed corneal ulcer with proptosis with periorbital edema and ecchymosis, whereas left eye was very much normal. And fundus examination showed left eye vitreous hemorrhage. On B scan, it was confirmed, and treatment, right eye temporary torsorrhaphy was done. Left eye self-resorption was seen in 3 months. In fourth case, 27-year-old with RTA, on CT he had SAH, on fundus he had vitreous hemorrhage. Patient was observed for few months, and self-resorption was seen in 4 months. In case 5, 41-year-old patient with RTA, CT was suggestive of SAH. On fundus examination, vitreous hemorrhage with focal traction was noted. On B scan, it was confirmed, and patient was taken up for internal procedure. Discussion: the first conservative form of management would be to monitor patient for blood resorption and spontaneous visual recovery. After 3 months of monitoring blood resorption with no improvement, and in conditions like non-resolving VH in patient who has monocular or dense binocular vitreous hemorrhage associated with retinal detachment, vitrectomy is very much required. Whereas in pediatric cases who have greater risk of amblyopia, it's better to take them for early vitrectomy. Late complications of intraocular hemorrhage such as epiretinal membrane formation leading to macular pucker can also occur. Thus, early diagnosis and timely intervention minimizes disease progression and enables better rehabilitation in most of the cases. Conclusion: Terson syndrome presents a unique clinical challenge, often serving as an indicator for underlying intracranial pathology. Though rare, intracerebral hemorrhage is associated with intraocular hemorrhage, hence screening patients of head trauma who are on supportive care, who cannot verbalize their visual loss, will help in diagnosing and intervening early. Neurological outcomes and mortality rate is 20 to 60% more worse in patients associated with intracerebral hemorrhage and Terson syndrome than patients who have intracerebral hemorrhage alone. Thus, we can conclude that importance of making fundoscopic examination mandatory for all head injury patients to prevent permanent impairment of vision. Thank you so much. These are my references.
You said the neurological prognosis is different if you have a Terson syndrome associated.
Yes, sir. There was a higher rate of mortality.
What could be the cause? Like why?
Disability and...
Not disability. No.
Yes.
If it were to cause Terson syndrome, the amount of SAH and the pressure rise in the pathophysiology is so severe probably. So that is a surrogate marker, not directly related to
Not
Terson
right,
syndrome.
yes.
But how do you exclude? You had 5 cases. Even your RTA can also produce a closed globe injury and a vitreous hemorrhage.
Yes, sir.
So any care was taken to exclude an isolated traumatic vitreous hemorrhage as a part of closed globe injury, as a part of RTA, than this? Was there anything that was done to show the pathophysiology is working in the way it has
So,
to?
all the 5 cases which I have concluded in my study, they had anterior segment was normal, and only on fundus imaging there was vitreous
No
hemorrhage.
ocular trauma,
No
whatever
ocular
cause,
trauma,
even no
sir.
closed globe
No
injury,
ocular
no lid
trauma.
edema, no ecchymosis.
Only the 4th case, other eye had ocular trauma, sir, but on fundus imaging, the right eye was normal, whereas the vitreous hemorrhage was only noted in the left eye for the 4th case. Other than that, all the other cases had normal anterior segment.
What the sir is asking is, all cases of intracerebral hemorrhage, if they have got vitreous hemorrhage, it means it is Terson syndrome?
Yes, sir. Internal limit.
Just a diagnosis that we make, but typical Terson syndrome has the way that you explained. So there's a rise in the CSF pressure, it is going to strangulate the venous flow, and then it is going to cause a bleed in the vitreous cavity.
It's not necessary that we will have some eye anterior segment finding in case of traumatic vitreous hemorrhage. Anterior segment can be absolutely fine, and we can land up in vitreous hemorrhage maybe due to PPD, in contact of injury, etc. So that is not exactly clear-cut diagnosis.
And during the head injury, nobody looks at the eye.
Yes.
He may report you after 2 weeks after the head injury. By then, the eye, all the
Could have
anti-segment signs would have disappeared.
Yes, sir.
Yeah, she concluded that all these cases should be examined by the ophthalmologist as well. So thank you very much.
Thank
Good
you so
paper.
much.
So our
Next speaker is Dr. Mandar Jogodekar.
Good morning, everyone. I'll be fast in this presentation. In 2022, laser shows were used extensively in many cultural events, particularly in the Ganpati process in the 2022. This is a representative depiction of the laser shows where the laser beams were aimed directly at the crowds to increase their participation, and a sudden increase in premacular hemorrhage cases was seen in this period. A compilation of these cases is being presented with the aim to present the morphological features of these cases. It's a retrospective analysis, and all consecutive cases between May 22 and April 23 were included. The inclusion criteria is a history of laser exposure and the retinal injury and examination. All the cases with unconfirmed or unreliable history of laser exposure were excluded. A demographic analysis was done. Image analysis of fundus photographs was done. Images were excluded if too blurry or details not clear. Treatment records were analyzed. Visual acuity and final outputs are analyzed at 3 months interval. And statistical and correlation analysis was done. We included 51 patients of 51 eyes of 51 patients with overwhelming male dominance, 98% with average of 24 years. Eye laterality was equal, and no patient was wearing glasses at the time of exposure, but 11.7% had mild ametropia. This chart shows the level of involvement of the patients in the procession itself. 52% were non-participants, where they were not dancing or not moving along the procession. They were just watching the procession or just passing by the procession. 29.4% patient gave a history of laser light sweeping across the eyes, directly followed by the loss of vision. In image analysis, we found 42 photographs were available, 2 were excluded, 40 were analyzed. This chart shows the size of hemorrhage ranging most commonly from 0.5 to 2 to 3 diameters, with average of 1.29 millimeters and maximum of 5.4 diameters. Varied shapes of hemorrhages were seen, commonly pair, and most common location was central. This is a just an example of varied types of presentations we saw. The presence of white spot was noted in 33% of cases, presumably by the laser injury. The location of was subhaloid in 37%, sub-ILM in 42%, and in both layers in 20%. The OCT passing through that white spot showed a hyperreflection at the white spot, indicating a laser injury and hyperreflectivity of the hemorrhage. The FFA was done in one case which showed the vascular staining, presumably because of the vascular damage. Hyalotomy, laser hyalotomy was preferred in 55% cases and 45% were observed. This is the final and presentation and final logmar visual acuity. With the final 42 patients obtained 6.6 to 6.9 patient vision, and only 2 patients had vision less than 6.36 at the 3 months. No correlation between presenting and final vision was found. Significant correlation was found between cultural events and incidence of cases. This is a time series analysis where we have plotted the incidence of laser exposure and the dates juxtaposed with the major cultural events. So we can see that in this graph that all the events coincide with the cultural events at the incidence. In complications, only 2 patients had poor vision, and epiretinal membrane and RPE mottling was seen in each cases. In conclusion, it's a predominantly male presentation. It's a varied presentation of premacular hemorrhage in both layers and varied shapes. It has usually good outcomes, but not without complication. Its limitation is a shorter follow-up of 3 months. Maybe complication can arise later on. Strong history of laser exposure was associated, and temporal association of the retinal injury with the laser can be established with this history. We need to further carry studies regarding the exact possible mechanism of the injury. And as no proper nomenclature is established, we refer this as a non-occupational laser exposure retinopathy. Thank you.
Now Now you said 50 out of 51 are males.
50, yes.
I mean, why is this?
Most probably because of the level of participation in this.
No, there were also bystanders, you said, people.
Yes,
so
yes.
maybe women avoid such, you know, number one, or they were probably, smart enough to avoid that exposure when it comes across. But is there any kind of, I mean, I don't know, just have you done any research? Like, is there any SOPs regarding the recreational use of laser in the from the government or something, or it is just that
In India, there is no, there are no guidelines.
it is supposed to be in the air? It
It's
should
supposed
be.
to be
It should
there,
not supposed
to be. Even if you can project into crowds, but there are MEP levels are established, maximum exposure levels. It should not go beyond that MEP layers. But there is no one
Intensity
to,
and
there is no one to implement it on ground.
Any knowledge about the wavelength of those lasers?
These lasers are both visual range laser most of the times. Not usually green lasers and the red lasers are used.
Did you try to elicit history as to repeated exposure? Was it a single sweep of the laser, or people gave a history of repeated exposure?
They didn't have that
Because
much
it's-
history, but it was, that
Laser has to be extremely strong, because if even a single
that's-
sweep,
Yes, because the
Single
30%
sweep can,
patient gave that
if it's
history
in
that
the right-
they saw the laser swiping across, and which was followed by directly bleed. or
So
loss
all of
vision.
them resolved.
All of them resolved.
Okay.
Either with treatment or with a follow-up both.
So have you got any case with laser pointer? Because recently laser pointer cases are
Yes,
coming
I
up.
agree. I haven't included in that. This
Okay.
is specifically for laser
That is
shows.
occupational use.
This is
No,
This
this
is
is not
non-occupational.
occupational, but
children also
misuse, we can say.
misusing, and so many cases are recently coming up, and that's not treatable also. That's
any bilaterality,
no bilateral.
all unilateral.
All unilateral.
It's a very rare thing for it to really go through both the things.
It's where you are
Just a one
standing in the,
swab. Yeah.
if you're
just
perpendicular
sweep
to the
across.
sweep
Angles
one eye.
will be different from both eyes. Angle of incidence will be
It's
different.
the angle of incidence, so probably one eye will be more exposed depending on which side you are. Probably. Unless you're straight-eyed, then you can have a bilateral.
Also, people who have peripheral, those white dots burn without a bleed, they may not come to you.
Yes.
So
obviously.
only
They
which
would have not
affected,
reported.
Only vision,
which
those
had-
have vision affection.
and covering the posterior pole only had come to you probably.
Correct.
So Ganesh Visarjan was the most common one.
Most common in that, but other also processions were there.
A good observation. Thank you.
Dr. Iram Tandel. Dr. Iram, next presenting author. Not here. Dr. Sushank Bhalera.
So, good morning everyone. I'll be presenting on rare ocular injuries by bird beak, its visual outcomes and factors affecting it. So, bird-related eye injuries are rare, and majority of them goes unreported. Most of them are by owls and rooster. Children are naturally curious and particularly drawn to attention to that living creatures, and roosters have a known site of child's eye as a site of attack. It can lead to retinal detachment, lens abscess, traumatic aniridia, post-traumatic endophthalmitis, phthisis, and early wound repair, iris abscission, anti-vitrectomy should be done, and serial B scan and perioperative antibiotics should be given. So we aim our study to evaluate the outcomes and identify the prognostic factors in patients with ocular injuries by bird beak treated at the tertiary eye care center in South India. It was observational study approved by IEC, and patients with bird beak injuries between 2011 to 20 were taken in study with follow-up of 3 years. We collected data on age, gender, mode of injury and size of laceration, and examination we did was visual acuity, slit lamp, fundus and B scan. Appropriate statistical tests were used, and p-value less than 0.05 was taken as significant. It was 27 patients, 18 were males. The average age was 20.46 years, and the mean length of corneal laceration was 3.96 mm, and visual acuity was better than 20/60 in 4 cases, and worse than 2200 in remaining 23 cases. No perception of the light was noted in 5 cases. So it was rural in population in 16 cases, and bird beak was causing injury in 25 cases, scleral involvement in 3 cases, infected tear noted in 5 cases, hyphema in 6 cases, iris prolapse in 4 cases, non-iridia in 2 cases, and vitreous prolapse also in 2 cases. Traumatic cataract was noted in 5 cases, retinal detachment in 2 cases, endophthalmitis in 7 cases, and surgery required in 18 cases. One surgery in 18 cases. So UCVA was a significant factor. Also, length of the tear, lens status, and duration between trauma and surgery was a significant factor. The true incidence of such injuries is largely unknown. Hence, our study is making significant in contributing to know its incidence. So, surgical intervention was done in 66% of cases, like corneal laceration repair via surgery, cataract extraction were the most commonly performed surgeries, and repairing can be challenging also due to their complexity and potential loss of tissue. Some required second surgery too. So traumatic aniridia, traumatic total iridectomy was there in some cases, and ocular injuries caused by bird beak often result in endophthalmitis. So dirty wound, delay in primary repair, ruptured lens capsule are independently associated with development of post-traumatic endophthalmitis, and our study observed 25%, 26% of cases, which was higher as compared to other studies done in past. So length of laceration, lens status, duration between trauma and surgery were our factors which were significant, and limitations of our study are retrospective nature and small sample size. Coming to conclusion, prompt management and appropriate intervention is the key in bird beak injuries like other injuries, and a critical role of timely surgical management and avoidance of multiple surgeries within first week should be understood. And we also identified prognostic factors like influencing the initial visual outcomes, which include tear length, lens status, and time interval between trauma and surgery. So role of public awareness to prevent these untoward injuries also plays a role. Thank you.
Exactly.
Any
He
culture
said
reports available?
all and
Yeah,
rooster, but all
two were having fungus, and
get
remaining
more
were
fish
in 2
eating
cases
outside
no
the
organism
water
was
than in
noted,
bubble
and
than
3 had a gram positive bacteria.
We didn't understand how exactly it happened. What is bird beak means? What birds? What happened? I mean, how can it be so severe? Like,
Yeah,
I mean, did you
it's
really
like
go into the actual incidents? Because if you want to prevent it, we should know how it happened.
in some villages, what the children used to play, they used to get these small roosters in 5 rupees. So usually their parents used to give them to play with them. So they buy that 5 rupees ka rooster, chota, and then children used to play. But while playing, that rooster suddenly come to their eye. So most of injuries were like that, and it's very common in villages of Andhra. They're a common game. They used to give it to kids. Yeah, just suddenly while playing they come to their eye. Most of the cases were like that.
Roosters
Very
are
few
also
had
school
some
going.
accidental injuries.
You said all. Is it that common? What bird you said? Except rooster, what extra bird you added in your slide? You said rooster one and
Yeah,
another.
most of them were rooster.
What are others?
In 2 cases there were like bat injuries, but that was other cases. Most of them were 80 to 90% were roosters, especially from villages in Andhra.
Children usually.
Hmm?
And children usually?
Yes, usual children, mostly are children.
Very interesting.
Thank you.
Probably that is related to that cultural thing. Probably that villages, as
Yeah,
you said,
mostly.
it's a play thing for them.
Yeah.
So
mostly.
could be that.
Thank you. Thank you.
We have the last speaker now, Dr. Anand Bhosle. I request him to come up, please.
Good afternoon, everybody. I'll be presenting a case on anterior segment reconstruction with artificial iris and a toric scleral fixated lens in a case of traumatic globe rupture repair. I don't have any financial disclosures pertaining to this case. The challenges in the recovery of globe rupture repair are aphakia, astigmatism secondary to the scarring of the cornea and the sclera, aniridia, and secondary chororetinal sequelae like retinal membrane formation and incarceration of the retinal tissue. So we had a 69-year-old gentleman who had a history of fall. He gave a history of previous cataract surgery. Apart from that, there was no other positive contributing history. Here we can see a globe rupture with a squashed globe. And on doing a thorough peritomy, we could see that there is a scleral tear at the limbus or maybe within 1 millimeter, and patient had aphakia. As we all would do, we did a standard repair with 70 Vicryl. AC was well formed, and here we can see a well formed AC, and the case was closed. At 3 months follow-up, the patient had aniridia, aphakia, and on OCT he had a peritoneal membrane. So the challenges we were facing here was high astigmatism, 4.5 diopter cylinder, but for surviving his BCVA was 612 parts. Patient was very keen on visual rehabilitation. So he had no iris and aphakia with high cylinder, so what could be done? So we decided to do biometry, which showed 20 diopter of IOL with almost 5 diopter of cylinder at 57 axis. We sent the patient's pictures comparing the better eye, which was the right eye, to the company, and they created an artificial iris for us. These markings are at 57 degrees where the desired toric scleral fixated lens is to be placed, and incisions and sclerotomies were done at 1.5 and 3 millimeters. After doing these sclerotomies at 1.5 millimeters, vitrectomy was performed and epiretinal membrane was peeled off from the macula so that the distortion is taken care of. We aim to fit the lens at 57 degrees. This lens was used with a CV8 Gore-Tex suture with a 7.0 size, and Gore-Tex is passed through the eyelets of the holes at the optic-haptic junction, and these are exteriorized. After exteriorization, we make sure that there is no entangling of the sutures, and this lens is folded with a hold and fold forceps and inserted into the eye through the 2.8 millimeter incision. Careful exteriorization is done and the lens is put in place. Here comes the artificial iris with fiber. 1 millimeter is subtracted from the white to white measurement of the patient. It is refined using a corneal refine, and the iris is separated. Again, Gore-Tex suture is passed through this, and in the same way the iris is implanted anterior to the lens. So this was a 3-month post-op result. At 3 months, the post-operative refraction stabilized with 612 parts vision as we had expected, with minus 0.5 sphere and minus 0.5 cylinder at 123 degree. So we can take a patient from a squashed globe to a beautiful visual recovery. So the take-home message is this is a novel and innovative technique for using biocompatible elastomer-based fiber artificial iris. Meticulous prior repair eases the secondary procedure. Aphakia, glare, and extreme astigmatism can be taken care of this novel technique. Long-term follow-up shows excellent visual rehabilitation. Thank you.
Dr. Anant, what about the stability of this artificial iris? You are only hitching at 2 places.
Yes, sir.
Okay. So how does it actually, kind of get that typical iris stability? Because it can be floppy, it can swirl around the thing.
So, sir, actually, the iris is also fixated at 4 points, 2 points each. 4 points. So can we please show the slide if you don't?
Other than the, you're actually, stitching the IOL also.
Yes, sir.
In another 4 points.
Another 4 points,
So
that's right.
4 different points.
4 different points, that's right.
What is intraocular pressure after surgery?
So, madam, intraocular pressure was low after the surgery because of so many sclerotomies. So we had to pad the eye next day. Slowly the pressure picked up. Fortunately, there was no choroidal detachment on B scan, so we kept him on oral steroids, and slowly the pressure picked up over a period of 1 week.
Okay, sir.
No, she meant that since there is no iris,
Okay.
so the post-op intraocular pressure is,
Yes, yes.
it should go up.
Yeah,
should go up.
it was normal, sir, because of the worry that the full size of the company iris would cause rubbing of at the angle. So we had reduced 1 millimeter and refined so that there was a gap between the actual angle and the artificial iris.
Well, if there is no iris aniridia, in these cases, the intraocular pressure tends to go up. Number one. Number two, what I want to ask you is, why did you prefer to have a toric eye in these cases? Because you're never sure how will the SFI will behave, whether it's going to have a tilt, whether you have a proper positioning or not. So why did you go for the toric IOL?
So because astigmatism was 4.5, even if we had put a aniradial lens, so that again incision of 8 millimeters plus this 4.5, total we don't know how much he would have been having. So we tried to reduce the astigmatism as much as possible, which was 0.5.
I don't know, but then in SFL having a toric IOL is something, you know.
No, it's
And
a,
because
it's
the
not
lens
SF, it's a
itself-
normal IOL.
It's a normal IOL.
Normal IOL, a normal toric IOL which is stitched to the
We
thing.
stitched to
Yeah,
the
there
sclera.
is a tilt also of the IOL.
Ah,
It's
that's
just-
an
yeah.
additional thing.
Yeah.
So if you, that is a possibility, but probably it's a gross astigmatism probably. What was the outcome? I mean, post-operative
Post-operative,
residual
he still
astigmatism.
have he still had
No, residual astigmatism. How much?
was
is it?
0.5.
Okay. That's
He still had that. The good thing was we could fix it at 4 points. So probably because of that I measured the from the limbus 3 times. Every time is to mark, measure and make sure it is the same so that there's no tilt on either of the sides.
But one thing, this iris would have also probably prevented the tilting of the IOL.
That's
That could have
exactly
been an
right.
additional
So
anterior stability
anterior,
to
it
the.
had an anterior scaffold which prevented movement.
Yeah, sounds good. And how about thinking about this pinpointed pupilloplastic kind of a very small pupil you could have given so that it takes away all the aberrations?
Sir, in this it is complete and total aniridia, so I did not have the option of.
You had the pupil inside, isn't it?
No
so people
pupil.
could have been
No,
still
can
smaller.
you customize the pupil? We are saying.
Customized.
Can you tell them that I want 2 millimeter pupil?
No,
thin?
sir. So they make exact 3.35 millimeters for all. It's a standard size. So they have come to this.
Normal
conclusion.
scotopic pupil of humans.
Yes, yes.
And do you have a case in point for having aniridia IOLs which also have the toric component? That would be a better solution.
Yeah.
Long term.
so
That's
the-
a case in point for actually going ahead in that direction.
So only problem with that is, sir, the length of the incision is again big.
Yeah, agreed. But then, like Sir's point was, the fixation at the sclera itself induces astigmatism. The suture, it will vary from case to case. Right now, you had 0.5 residual, but in maybe a series of 5 or 6 cases, it would vary depending on the.
You can have a foldable toric aniridia IOL, but only the cases are less. That's why there is not much
It's
of a
not.
thing.
It's
Now it's only
and
rigid.
probably customized.
Yeah. In future, maybe we'll have a foldable toric aniridia lenses. Yeah, good try. I
Very
think
nice, very
very encouraging result.
Thank you, sir.
So with this, we end of there is the end of the session, and may I kindly request all the speakers to come to the dais and let's have a photograph with everybody. And
Any absentees, they have come up for Dr. Raj Vador, Dr. Shivangi Singh, Dr. Iram Tandel. No. So that's it for us.
so please take the sheet.
Yeah. ये निकालिए यहाँ से. ये निकाल लो.